Hello, good morning. I'm Dr. Nubile.
And I'm Dr. Sotiria Palioura. And welcome to the second episode of our two-part independent medical education interview series on ocular surface disease.
So today we are focusing and turning our attention to a chronic and often underdiagnosed condition that drives a surprising number of ocular surface symptoms, which is Demodex Blepharitis.
And we'll look at why this condition is so common in ocular surface disease patients, how to spot it, and how to choose the best treatment, covering both established as well as emerging approaches that could change how we manage this condition in the future.
So we will start with the results of the ESRS clinical trend survey that was made recently in 2024 on the diagnosis of Demodex Blepharitis. As you see here, only 20% of the doctors regularly screen the patient for their Demodex Blepharitis.
I do screen all my patients. I think I was one of the people that answered yes there. So I always ask the patients to look down when I examine them. That's how I start my exam. And I look at the base of the lashes. And if I see colorets over there, then I know that that's Demodex. I don't have to epilate the lash and look at the microscope. The colorets is a pathognomonic sign for Demodex, and it's different from other causes of blepharitis like scurf, which is not at the base of the lashes.
Some of the patients are symptomatic, and you should consider what is the entire status of health of the ocular surface, because then you would see that some patients have coexisting meibomian gland disease, some patients have inflammation, some patients do not have. So you need to categorize your patient with colorets and having Demodex Blepharitis into two big categories: who is symptomatic and need treatment for that reason, and who is not symptomatic, and so probably you shouldn't need to treat unless you're undergoing surgery.
Once we start looking systematically at the lashes, we find out that it's actually quite common, especially in the aging population. I would say that at least 40 to 50% of the patients I see will have some degree of Demodex Blepharitis, and like you said, some are symptomatic and some are not, or they're not because they've been used to having morning itchiness, for example, or having this intermittent feeling of foreign body sensation, that because they've had it for a long time, they feel it's normal. And once you point it out to them, then they're happy to do something about it.
Actually, the epidemiological studies perfectly match with your daily practice results, which is that approximately 50% of the patient adult population, so it's highly prevalent. That's an important point. Patients are suffering from condition that is always underlooked, is correlated with other kind of ocular surface alteration. And when you explain to the patient, look, probably you did a lot of treatment, you did artificial tear, you did a lot of anti-inflammatory, steroids, whatever, but probably you forgot to treat one thing. And when you tell them, look, you have a parasite, this could be a cause or a coexisting or condition that is worsening your symptoms. Once you make the diagnosis, the next step of course is choosing the, if possible, the appropriate treatment.
What we have available is foams and cleansing solutions that have tea tree oil. So that's what I recommend to my patients, to wash their lashes twice a day. You have to explain to them that they're not going to see results immediately. They have to be consistent with this and reevaluate after 3 or 4 weeks whether they're actually feeling better. The thing is that all this tea tree containing cleansing solutions and foams that we have available, they just decrease the load of Demodex, but they're not gonna ever kill it completely from the lashes. So they have to be, even when they feel better, they have to continue and be compliant for almost the rest of their lives.
As you said, the results are not so immediate, and probably because inflammation that was triggered by probably the dead mice. So you need also to control inflammation in those patients. And so the anti-inflammatory therapy can speed up the results. So if you match the approach that is aimed to eradicate the mites and then to control the inflammation, I found it quite useful for having patient relief from symptoms earlier.
Sometimes patients will volunteer that they have a very busy life and they're not going to do anything at home, or they'll try to do something but no guarantees. I will be recommending an in-office procedure from the beginning when I see them, even if they have mild disease, where basically we would do microblephar exfoliation and clean the lashes one by one, and they know that this is not a cure. They will have to repeat this procedure. When I see heavy collarettes, like half of the lashes, like a collarette, I also think that in those patients, it's helpful if you can reduce the load in the office and then they also do the treatment at home. So in those situations, I will start with the office and then continue at home. And in compliance issues, I also recommend office procedures, and the patients are actually grateful. They like to have an appointment even in their busy life and come and get it done rather than having to scrub their lids twice a day.
If you want to motivate the patient, if you show to the patient, a slit lamp photo or even an iPhone or telephone photo of their eyelashes, and you show them that there are these collarettes, and these collarettes means this Demodex infestation, they will be much more motivated. This is what I found.
Now let's look at what's changing the landscape. There's therapies that are already available, Lotilaner ophthalmic solution.
This was approved recently in the US by the FDA. It is an eye drop that should be administered just once or twice a day for 6 weeks. Actually, the life cycle of the mites is approximately 2-3 weeks, and this means that with 6-week treatments you are quite sure to eradicate at least 2 life cycles. This means that the results in eradicating the mites are so promising as far as we trust in the US data, but I think everything should be similar worldwide. So the mechanism of action is promising because with all the other methodology, you're not killing mites, you're just cleaning them off and making their life more difficult. So what does the latest clinical trial data from the US tell about the efficacy and durability of Lotilaner?
Yeah, the data is impressive. In 70% of the patients, the mites were eradicated after treatment with Lotilaner, and actually 90% of the patients felt that they had a clinically significant improvement in their symptoms.
Which is a result that is significantly better from what we can achieve with the other treatment that we use so far.
Yes, it's
We're
much
waiting
better.
for this in Europe as well.
Absolutely, we're really excited about having it here too.
The fact that you can really treat the disease and probably in a vast majority of patients eradicate the mites, this is significantly improving our results, because actually you're just not mitigating a disease, but probably you're curing a disease.
So thank you for joining us in this 2-part EuCornea Independent Medical Education video interview series on ocular surface disease. We hope this conversation helped you sharpen your approach to diagnosis and treatment so your patients can see, feel, and live better.